Hi, everyone. Welcome back to the 2018 Brain Health Online Summit. I am Amy Zellmer from Faces of TBI, and I had a TBI from a fall on the ice in February of 2014, and myself, along with Dr. Jeremy Schmoe from Minnesota Functional Neurology, we saw a need in the brain injury community for more training and education on alternative healthcare methods and modalities for those suffering from the lingering effects of a brain injury. So each weekday during the summit, you're going to hear from a presenter who will share their experience either working with brain injury patients or their own real-life experience living with a brain injury. So today I'm here with Dr. Jeremy Schmoe, and he is a Minnesota doctor and owner of Minnesota Functional Chiropractic and Neurology. He is a leading practitioner who works with patients from all over Minnesota as well as the U.S. He is board certified through the American Chiropractic Neurology Board and has completed a TBI certification and is a fellow in brain injury rehabilitation. He also helps manage patients with complex neuro and metabolic conditions. He specializes in helping patients who are suffering from concussions and complex brain injuries. So today he's going to be talking about concussion eyes and how our eyes are affected after brain injury, which was definitely my biggest problem when I found Dr. Schmoe.
Yeah, so I guess we'll jump into it. So with traumatic brain injury, we know that your eye movements are definitely going to be affected. So the visual system uses the entire brain, and there's research that shows that 90% of people after TBI are going to have their eye movements affected. So their ocular motor system is definitely integrated with TBI. We have to try and figure out what circuits are off visually and develop very unique and novel rehabilitation to try and get those eye movements to be better. So a practitioner that knows about eye movements can get a good idea about what areas of the brain are dysfunctional. All right. When you really break it down with eye movements, your brain just really wants to know where you are in space. So you got to be able to keep your eyes steady, but you also need to be able to move your eyes quickly and pick up other targets. So there's different classes of eye movements. I'll break them down a little bit and kind of go into what we see clinically when there's issues with the vestibular ocular reflexes or visuals with, gaze fixation or issues with pursuits or saccades. So, I guess the main thing that I saw that was off with your eye movements is that it was your optokinetic reflexes. Do you remember those?
Which one was that? Oh, that was the red and white stripe.
Yeah. So, people need to know where their bodies are in relationship to things moving around them. So when targets move in front of you, reflexively, your brain is going to take in that information, and you're going to have, say, if we're going to the right in front of you, you're going to pick it up with a slow phase and then fire your eye movements back in the opposite direction to pick up another target. So that's optokinetic nystagmus right there. All right, so that's one class of eye movements. Those were definitely affected with you, especially when we were going up and down. Mm-hmm. All right, so say, for example, if you were probably doing a lot of scrolling on the computer, that would cause you to get tired, to get fatigued, to have...
It would make me dizzy sometimes.
Vision, dizzy, feeling like you're moving or having motion. All right, yep. So that's just one class of eye movement. There are vestibular eye movements or vestibular ocular reflexes. So say if I'm looking at you and I move my head this way, I'm going to activate my vestibular system on the right. That information is going to go into the brainstem. That's going to activate certain nuclei, vestibular nuclei, which have pathways that fire up to ocular motor nuclei that cause the eyes to go in the opposite way. So if I move my head to the right, my right medial rectus and my left lateral rectus are going to be activated. So we have appropriate eye-head stability. So there just has to be a perfect gain and sensitivity of how your vestibular system moves and how the eyes move equal and opposite. All right, so if I go to the left, my eyes have to shift back to the right. If I tuck my chin down, my eyes are going to come up. If I bring my head back, my eyes are going to go down. So those vestibular reflexes, vestibular ocular reflexes, they happen very quickly, within like 15 milliseconds. So they're the fastest reflexes that happen.
Wow.
The visually mediated reflexes, those are taking around 100 milliseconds. So one of the things that really is that can cause perturbation into your nervous system is when you're walking, when you're moving and you have a heel strike, that information goes up into your head and your head has to move. What's going to compensate for that is your vestibular ocular reflex, right? Because the visual system isn't quick enough to compensate for your head movement. Does that make sense?
Mm-hmm.
Right? So if your vestibular ocular reflexes are off, then you're going to be more dominated by using your visual reflexes. All right. So there's all this integration between vestibular and visual, and these systems have to line up perfectly. Okay. So you got your vestibular system, you have your canals that fires into the brainstem, that fires up to the eyes, up to cranial nerves 3, 4, and 6. Those control all the eye movements. But then that information actually also fires down into your spine and down into your legs. And those are called the vestibulospinal reflexes. So say if you're walking out and you slip and fall on the ice, those reflexes should kick in and you should fire your arms and your legs in a pattern to catch yourself. All right. So those are reflexes that can be off with people after traumatic brain injury. Right.
What about walking into things like your depth perception?
Yeah. So there's other types of eye movements. One of them is called vergence. So your ability of your eyes to either converge or diverge and deal with depth. That's a movement that can be off with people too. So when you're looking at something, your eyes have to come in if you're looking at something close. So your medial recti muscles contract, but then your pupils also basically constrict. So that, that's called accommodation. That can be off with people with traumatic brain injury. So they could have issues with visual blur, issues looking at things that are close up. They can have eye strain. They can get headaches. So that's definitely something that we see every day with our patients. The most common thing that I see are issues with visual fixation. So there's all of this complex circuitry in the brain that fires in, from the cerebellum, from the basal ganglia, from the frontal lobe, which fires into the brainstem to activate all these circuits to keep your eyes steady. All right. So your brain wants your eyes to be steady so you can take in that information. And one of the things that we'll see is people will have different oscillation movements of their eyes. Right. So they're trying to keep their eyes steady, but you might see a jerky motion off the target. All right. And that's something that can affect, and that could give you headaches, that could give you visual blur, that could give you issues with reading and tracking. All right. All of those little movements that you see with the eyes when people can't visually fixate, something has to compensate for that, and it's usually the neck. All right. So if you see all these jerky motions of the eyes, you usually will see increased tone in the cervical spine.
As a result of whiplash?
As a result of their inability to keep their eyes steady on targets, you will get tightness in your neck.
Oh, so it's coming from the eyes to the neck.
Yeah, it's coming from the eyes to the neck. So,
I think that's you were telling me once, if you're watching TV and all of a sudden your neck hurts. Because I remember that kept happening to me. And I was like, why is my neck so sore? And you said that was from my eye movements.
So, you're watching TV. And there's different motions that are going on the TV. So you got to be able to keep your eyes steady, but then you also have to pursue and follow targets, all right, which are moving on the TV. Mm-hmm. And that could give you an issue because your eye movements could be jerky, all right? You also have to move your eyes quickly to pick up other objects, and those are called saccades, all right? And then when you're sitting there watching TV, you might move your head, all right? So then your eyes have to move equal and opposite. Those are your vestibular reflexes. And then you have to deal with complex motion in front of you, and those are the optokinetic reflexes. And then maybe you get up and you move while you're watching TV, and you move a little closer, and your eyes have to converge, or you go back away, or your eyes diverge. So those are all the classes of eye movements right there, and you're going to get those in everyday real life. Mm-hmm. All right? Clinically, we look at those by doing a very detailed bedside examination where we look at all those reflexes. So, in functional neurology, we really pride ourselves on having a very detailed assessment of our patients at the bedside without even using sophisticated technology like VNG or saccanometry. There's all sorts of, technology that you can use to assess these eye movements. but you can pick up a lot of it at the bedside if you do a lot of exams and you see a lot of people with TBI. So, I mean, a lot of the rehab that I come up with is from stuff that I just see at the bedside examination. And you might not even see these things on your diagnostics. Like an example, I have a soccer player that I'm working with, high-level soccer player. He came in, everybody says that he looks normal. All of his eye tracking is normal. His vestibular assessment is normal. His balance is normal. His visual acuity is normal. We know that vision is way more than visual acuity. There's a lot of complexity that goes on. And I take out my ophthalmoscope. I have him cover up his eye. And I go and I look at his retina. And I can see that he actually has some subtle, slow drifts of his retina. So his eyes weren't perfectly steady at rest, but that wasn't even picked up on our BNG analysis.
Wow.
And he had a lot of troubles just walking and moving and running. So when you move, your head's going to move between 0.5 to 5 hertz with motion. So that heel strike comes in and causes that vestibular ocular reflex, and your neck has to compensate. So with him, he would move and then he would get oscillopsia. So the world would look like it was moving when he was running, which would lead to, motion sickness and nausea and stuff like that. So those are the things that we see with our patients every day. And we have to do a very detailed exam of all of those reflexes. So vestibular ocular reflexes, gaze stability and fixation, ability to follow objects smoothly called a pursuit, saccadic eye movements, which is your ability to move your eyes quickly and hit targets. We look at nystagmus. All right, we look at optokinetic reflexes. So if you move a moving strip in front of you, do your eyes pick up the target and jump to the next one appropriately? All right, and then do you have appropriate convergence and divergence? What do your pupils look like? Are they huge? Do they constrict appropriately when we come in? Do your pupils constrict and accommodate appropriately? All of those things can be affected with TBI. And what happens, you get these injuries and you get this acceleration, deceleration, you get a lot of torsion and rotation, and midline areas in the brain get affected, and these visual pathways seem to get affected a lot. Okay? So, in the cortex alone, I mean, there's over 30 visual areas in the brain with 300 bidirectional pathways. So they're all talking to each other. All right? And that's just up in the cortex. And then as you go down into the brain, into an area called the midbrain, then you have these different nuclei that help you move your eyes. All right? So a person could just have an issue with just a weakness in an eye muscle, or a weakness in elevating or depressing the eyes, or a weakness in the resting tone of their eyes with one eye being in or one eye resting out. So they can have strabismus, they could have what are called phorias, or you can just see the eye out called atropia. And you see that with traumatic brain injury. So the cranial nerves 3, 4, and 6 have like a long intracranial pathway. And when you get these hits, you can get shearing of those nerves, right?
What was that with me? So you tipped my head to the side and watched my eyes? That's how you found one of mine?
Yeah. So I was looking at your torsional motion of your eyes. So as we rolled your head this way, we were looking at the counter roll of how your eyes counter roll opposite. And that wasn't appropriate for you. So that was a change in the vestibular reflex of how that system communicates with different nuclei in the brainstem to cause your eyes to counter roll the opposite way. And then what I did is I went in there and I did some different eye exercises, combinations of head and eye movements to put your eye muscles in different mechanical advantages, to activate them in ways that would cause intorsion and extorsion of the eyes in the appropriate way. So those are some things that you'll see with people are the communication between the vestibular and the nuclei in the brainstem that fire out to control the eye muscles themselves. Like those pathways can be affected. But it wasn't actually an issue with the eye muscle themselves.
Right.
It was an issue with the central circuitry. So a lot of these issues, people will have, vision exams and, different things, and their visual acuity is fine. All right. But what about if they have to move? All right. So that could be an issue. So vision is way more complex than just visual acuity. And, everybody knows that now. There's extremely talented, NORA board certified neurooptometrists that I work with every day. We refer to those people, and they refer to us too. So we have good working communication with other providers, and they know what we're good at. I know what they're good at, and what we're good at is figuring out that central circuitry, developing unique, specific, novel rehabilitation exercises for that one individual in front of you. So every person with a traumatic brain injury is going to have something totally different than the next person.
Right.
All right. People's brains are complex. People have other things that were going on with them prior to having their injury. You could have already had a aphoria or atropia or changes in your convergence before you had your injury. All right. You could have already had a visual vestibular deficit before you had your injury, and then things come out even more after your injury. All right. You could have anxiety and depression before you had your brain injury already. You could have had a gut infection or inflammation or something like that, or diabetes or an inflammatory reaction, or Hashimoto's, or any other type of metabolic dysfunction, Lyme disease, mold. You can have things that are going on prior to hitting your head.
Right.
So that's something also that at my office, we bring into the table of looking at, neurology, metabolic, and structure, and kind of blending all those worlds of functional neurology, functional medicine, and manual therapy, chiropractic together. So those are some of the different eye movements that we look at in our office, and we do that every day with a very detailed bedside exam, and then also using technology like BNG, where we use infrared goggles where we can assess eye movements, and we can video record them, and then we can show them to patients. And
that was really cool to be able to see that.
And when patients see those eye movements and they see what we're talking about, they get it.
It was very validating.
Yeah. It's validating for your system. It's validating for your brain. It's a part of the healing process to be able to see that dysfunction in front of you, and it starts to jump out at you when you really see it. So that's very cool. So basically, when you break it down, your brain wants to know where your body is in space. You have muscles, you have eyes, you got 6 muscles on each eye, you have canals, you have a cerebellum, you got gravity. So gravity loads these muscles, it gives feedback into the cerebellum. The cerebellum is the big calibrator, and it integrates a lot of these ocular motor movements. So it goes up, it has all this talk with this complex mathematical equations that are going on in the brainstem to help you develop, appropriate burst of activity of eye muscles to move your eyes to targets, to keep your eyes on targets, to follow targets smoothly, to move your eyes left and right and up and down, to rotate or tort your eyes appropriately. And a lot of that is being calibrated by some very complex circuitry that gets injured with traumatic brain injury. All right, so the cerebellum fires up to the opposite midbrain, and there's a lot of circuitry in the midbrain for controlling eye movement. So if I go like this and I laterally flex my head to the right, that activates my right cerebellum. That fires up to circuitry, which is going to cause superior muscles on this side to help intort my eye, and then inferior muscles on the opposite side to help extort my eye. So those reflexes, they have to be perfect. All right, if they're not perfect, you're not able to get the appropriate feedback from your visual world. And what happens is that changes your maps in your brain of where you perceive your body to be in space. And then you start developing all sorts of different head rotations or contractions or elevation of shoulders, which puts your muscles in a different advantage, and that can cause pain. Does that make sense? So if you have something going on with your ocular motor system,
I had a head tilt.
Yeah, so you could have a head tilt, you could have a rotation here, you could have different posturing of your neck, and then that changes, and that can activate different pain-based structures peripherally in the neck and give you a referral up into the head and eyes. So you'll see a lot of patients that have issues with their eye tracking that also have a cervicogenic component to their symptoms. And that's an art form of trying to figure out, well, what came first? Is it a whiplash injury? Do you need to do manual therapy and acupuncture and chiropractic and massage and craniosacral? What do we do first? Do we do that, or do we go in and do vision rehabilitation? You have to try and look at all these systems and try and blend that together very uniquely for that one individual. And then that's what's going to make the change for that person. So the right frequency, the right repetition, the right amount of rehab, the perfect amount of rest, all of that stuff matters when you're trying to rehabilitate a very complex nervous system.
Mm-hmm. I remember before I met you, I had done the circuit, the neurologist, the neuro-ophthalmologist, the neuropsychologist, the eye doctor. So my eye doctor has known me for like 15 years. So she knew something wasn't right, even though my vision was fine, and I couldn't articulate what was wrong with my eyes. All I could say is like, something's just not right with my eyes. And my eyeballs actually hurt. Like, I remember she had me like look over to the right, and it was like I could barely look to the right. To the left was easy, but the right was really hard.
Yeah.
And you got to follow that thing that they bring towards your face, and I couldn't focus on it. And she's like, she was mystified. She's like, I really don't know what's going on with you. And then I shortly after found you, and it was like, I remember working like, I think maybe 2 weeks with you. And I remember getting in the car, 2 days, not 2 weeks. I remember getting in the car and driving home. And I remember being like, my eyes, like everything's crisp again. Mm-hmm. Not that like things were blurry before, but something just wasn't quite right with my eyes. And I just remember driving home going, oh my gosh, my eyes, like everything is crisp again. And it was just profound. And how, how simple, even though I wanted to kill you with some of the exercises, they're relatively simple. They're hard, but simple. And like just how that was able to clear stuff up so quickly. And I know people like don't believe me sometimes when I tell them, like, no, really, it was like a week. And I felt 80% better.
Yeah, so that,
and you hear that all the time. I know.
We hear that all the time, and we see it all the time, and it's complex stuff. And with having in-depth knowledge of all of these circuits, not only how the eye muscles move, but it's really important to know how the central circuitry works, and that's what we're good at. All right. So having that knowledge of how the central circuitry works helps us get very specific with the rehab. And if you do the right thing and you do it the right amount, you can make changes to the brain, and it happens very quickly. All right. That's neuroplasticity right there.
Right.
All right. So you can build plasticity and make improvements to people in a short amount of time. And that's what we did with you.
Mm-hmm. And, like I get asked too, like, well, does it last forever? Like, what's the catch? Right. Like people like just like, they're so skeptical when I tell them. And, like I've had a couple relapses, and we've done, like, I know how to do my exercises on my own.
Yeah.
So I do them at home. Like if I have like for instance, if I'm watching TV and like they do like a crazy, like a zoom, a pan with the camera, and they do all sorts of crazy effects. Sometimes I'm like, whoa. Mm-hmm. And then I'll sit and do my exercises, and it's fine. But there was a couple times where I know I had to come back in, and you had to do a few different things with me, but then it clears it right back up again.
Yeah. And that's what I like about what we do is we get people better. We try and get them better as fast as we possibly can, and then make them very self-sufficient to be able to fix themselves if anything like that happens. So when we send people home, it's not like, hey, come in here for a week and hey, good, see you later. You're getting videos of your exercises. We're recording you doing them. People can email us. We have built-in check-ins to make sure we're doing things the appropriate way. So, for you, with saying that you had issues with that panning and that moving around, mm-hmm. It was probably your optokinetic reflex that was a little bit of an issue still. All right. So that's what we have to figure out with people, and let them know what their triggers might be based off of what we see. And guess what? You don't want to stay away from those things. You want to go experience those and let your system start to reintegrate again. We can get people to look really good in these four walls, but when you get out there in the everyday world and you have to deal with depth and movement and one object moving this way and another object moving that way, well, things are moving in and out towards you, right? I probably just messed a couple people up.
I was just thinking that.
That can lead to some problems. So if you go in and somebody examines you in one room with a flat wall or in the dark, it's not the same as being out in the everyday world with a complex visual, vestibular environment where you're walking and you're moving. So that kind of brings me to my next point. We develop combinations of head and eye and body movements that are real world stuff. So we have to start with, getting your eyes steady. But once we do that, we have to start integrating body movement with combinations of head and eye movements and start making things even more complex. All right. So that's what we're really good at, is helping you deal with the depth perception, sounds that are going on in the environment too. That's something that we see all the time. So you'll see people, they hear a sound and they might sway in an opposite way or start to get dizzy. So we'll help remap your visual system and your auditory system together with different techniques that we use. Mm-hmm. And I think Deborah Zielinski talked about that a little bit with the Z-Pelt technique, which is very cool. So it's a very complex system. And what we see is it's multimodal. So we can make an eye movement better with doing like a hand movement or a body movement, right? You could make an eye movement better with doing a vestibular movement of the head and eyes, right? Make an eye movement better with giving somebody like some sound. All right. So I see a lot of patients that do eye exercises and even vestibular rehabilitation, and they're like, oh my gosh, I get so nauseous. I get so sick from this. But maybe you just need to do it in like a perfect order of visual first, body movement first or second, or do some eye exercise, or do it in a different order. And that's what we figure out during the week. What order do you need to help build plasticity in your nervous system?
And Jeremy, do you want to talk about why you do a week intensive? Like how does that work and what's the reasoning behind that?
Yeah, so the reasoning is that when we get to hang out with you for over 3 hours per day for 5 days in a row, you're going to see so many different things. I mean, halfway during the week, I might see you on a Wednesday and find something that totally changes the game that I didn't see on Monday or Tuesday, which helps you get better in the long run. So with the intensive, with seeing you multiple times per day, we're trying to build plasticity and get neurons to fire and wire together to help build your circuits. All right. So that's the main reason, trying to build plasticity. When you get to be with that person, also you develop just a really good connection with that individual. It's not just in and out and good luck, go to your exercise, to see you later. You build that connection, and people need that. People need help. People need us. People need us to be there for them. And they know that when they go home, like, we're going to be there to help them if anything ever gets off again. So the whole idea with the week intensive is to build plasticity in the nervous system and get those circuits to fire and wire better together.
Mm-hmm. Yeah. And I've had people ask me, like, what exercises do you do? Give me your exercises. And it's like, well, they're customized to me. Like, it might not work for you, or it can make you worse. And,
if you're doing exercises for somebody that has an issue with their torsion of your eyes going in the opposite direction of what you had, well, guess what? It's going to make them worse.
Yeah.
So that's what's cool about what we do, is we make it very individualized to each person. Mm-hmm. All right. Just this last weekend, we had a course with Professor Carrick, one of my mentors, and we spent 25 hours talking about advanced application in eye movements, talking about just burst neurons in the brainstem and how these omnipause neurons fire up to inhibit these burst neurons to keep your eyes from doing that jerk. So, that's all we do.
Wow.
Is nerd out on this complex integrated circuitry, and we're lucky enough to go into clinic every day and see people with these issues and apply our knowledge and try and fix them. Mm-hmm. So, and that's why I love doing what we do, because we're just continuously building on our knowledge, trying to get better. We're not just stuck in our ways of that's how we do it. So if I see something new or novel or learn about something, guess what? I'm going to try it tomorrow. And I'm going to have good observation skills to see if it's going to work for that individual. Obviously, if it doesn't work, then we're not going to do it. So observation is the best thing that you can do clinically. Take it all in, see what you see with that person, develop unique novel strategies for that one individual, not, doing the same exercises for every single person that you see, or the same adjustment or the same technique. Everybody's very individualized.
Mm-hmm. Yeah. And I know, since working with you, I've met numerous people who've worked with you, and, it's like everybody has the same reaction. Like it's just phenomenal how you can go. I was 2.5 years out when I met you, and you helped me in a week, and it's just this profound feeling of like, oh my gosh, I wasn't crazy, because I start to feel nobody can figure out what's wrong with you. And it's just such a relief to know that there's doctors like you and others on this summit who are knowledgeable and know how to help people.
Totally. And here's what's cool about the summit this year is, we have people from, the physical therapy world that are super trained in vestibular rehabilitation and doing amazing things. People from the medical field that are looking at alternative ways to heal people without drugs and surgery, nutrition and meditation and other techniques. All right. So we're really trying to integrate everything together. And my hopes for the future is that there's some sort of like integrated traumatic brain injury rehabilitation program that's multidisciplinary.
Yeah.
That's MDs, PTs, OTs, DCs, anybody who can help people can go in there and do that program. And hopefully that's something that we put together in the future. Because right now, most traumatic brain injury education, it's post-grad education.
Right.
So.
And, and I think that's part of my passion. I'm doing some keynotes coming up in March, and in front of 600 healthcare providers. And I hope that I can help bridge that gap, between the providers that really get it and the ones that want to get it.
Yeah.
And I hope that I can help bridge that gap. And, events like this summit, and, it's just getting the information out there, helping all of our wonderful survivor friends and patients, and helping the healthcare providers understand what else can be done to help us. So
it's things like this summit that are going to help other healthcare providers be like, you know what, I really want to get in there and I want to learn about all of these eye movements to help my patients better. And, I'm coming on here not saying, hey, I know everything, because I don't. And how could you? All right. It's all about observation. It's all about taking, your clinical skills and applying it to an individual, and, thinking outside the box. And that's what I love about what I do.
Yeah. Well, and I just appreciate you and everything you do. And I know how incredibly hard you work. and it's not always easy working with us brain injured people. So we appreciate
it. I have lots of stories. So I'm telling you right now.
Is there anything we didn't touch on that you wanted to talk about?
I don't think. Here's the thing. Like, I could talk for 25 hours about eye movements, and I could go into all the depth circuitry and these omnipause neurons and excitatory burst neurons and these different nuclei, but it's going to bore people to death. The basics are, your brain wants to know where your body is in space. You want to be able to keep your eyes steady, but you got to be able to release that fixation and move your eyes when you want to pick up other targets. And by doing that and having these appropriate eye reflexes, it helps you know where your body is in space. And that helps build maps. And those maps basically get transferred from an area of the brain called the superior colliculus up into the cortex, where there's a lot of complexity going on there. And I guess the main thing is, you might feel these symptoms and you might go get your vision checked and people might say it's normal.
Right.
All right. But it might not be normal. There might not be normal central processing that's occurring. There might be something that's going on, and we might be able to figure out what it is. All right. So if people don't know what's going on with you and you're a complex case and you have vision and vestibular symptoms and you've done all sorts of different types of therapies, find a local functional neurology provider or give our office a call, and we can send you to somebody, and we go from there. And we just want to get you better. All right. That's the main thing. We just want to get you better. And we have techniques that hopefully help do that if the doctor can do a good job and make appropriate observations and make a therapy program that's unique for you. All right. And, I help a lot of people. There's some people also that I don't help. All right. And that's just the way things are. All right. But we do help a lot of people. And at least when you come to see me, you can tell that we care about you, and we're doing our best to try and make improvements. And this stuff is complex, and we're going to give it our best shot to make improvements with you.
Awesome. Well, Jeremy, thank you so much for doing the summit. I'm so glad that we've had this opportunity to team up and do this 2 years in a row now. And I think, the feedback we got last year, we really are changing people's lives with this summit. So thank you for everything you do.
Oh, thank you.
And thank you everyone for watching. I hope you've enjoyed the summit. This has just been an amazing summit this year. And if you weren't able to catch all of the live recordings, you can purchase all of the recordings for $29, with the proceeds going to the Brain Injury Association of America. So be sure to check that out if you have missed any of these awesome presentations. So thank you again, everyone, and we'll see you again next year.